Welcome, everyone. Good morning, good afternoon, good evening, everyone. It's a great joy to have you join us on our webinar series. So our webinar series for today would be on supply chain and logistic management in primary healthcare. As most of you know, we have been organizing webinars on primary healthcare based on the WHO primary healthcare framework and operational levers. Our focus would be today in sharing experience from other countries as well as the challenge and the best practices. Before that, allow me to introduce to you, for those of you who don't know, the International Institute for Primary Healthcare. International Institute for Primary Healthcare is established by the Ethiopian Ministry of Health back in 2016. It envisions to become a center of excellence in primary healthcare. Our mission is to proactively engage and drive the advancement of primary healthcare towards the attainment of universal health coverage and health-related sustainable development goals. We do have different strategy teams, one focused on the national primary health care support, the other on the global primary health support, knowledge generation management, and advocacy. We have been building capacities on leadership and management and governance in supporting new innovations and improvement initiatives, as well as organizing different courses and programs. We are also working with local universities and other partners for implementation research. This year, we have organized an international conference on primary healthcare, which is attended by more than 500 participants in person in Addis from over 50 countries. Welcome again to this important webinar topic on supply chain and logistic management in primary healthcare. We have great speakers that are lined up. Allow me to introduce to you our moderator for today. Our moderator is Matthew Maganga, who is a senior registered pharmacist and a health supply chain specialist from Dodoma, Tanzania. He is currently the national coordinator for bottom-up quantification and overseas interventions related to electronic logistics management information system, including the redesigned logistics systems for about 6,000 health facilities under the President's Office's regional administration and local government. He has gained extensive experience in health supply chain management for the 7 years, while serving as the head of health commodities and diagnostic services in the Office of the President's Office, regional administration, and local government. Moreover, he has extensive experience of about 10 years working in primary healthcare at community level in numerous positions, including district medical officer, district pharmacist. He was the initiator of the establishment and rollout of drug revolving outlets in Tanga region in 2012, and has been heavily involved in the establishment and rollout of the prime vendor system across the country in 2018. The prime vendor system is an initiative to complement the supply chain gap in the availability of health commodities at primary health facility level. He has also been actively involved in the development of the following guidelines: National Supply Chain Key Performance Indicator, National Quantification of Essential Medicines, ARV's redesigned logistics system, and the information mobilized for performance analysis and continuous transformation approach in Tanzania mainland. Matthew Maganga holds a Bachelor of Pharmacy from Muhulimbi University and Allied Sciences, a Master of Business Administration, Corporate Management, and an MSc Procurement and Supply Chain Management from Mzumbe University in Tanzania. He is currently pursuing a PhD in Public Health at the University of Dodoma, focusing on strengthening the existing supply chain system to complement the commodity availability in primary healthcare facilities. Welcome, Matthew, and over to you.
Thank you very much, Dr. Antene, our Director of Programs, for welcoming me as a moderator of our session. Now, without wasting much of our time, may I proceed by introducing our first speaker, who is Mr. Seru Morris. Mr. Seru Morris currently is an acting commissioner for pharmaceuticals and natural medicine in the Ministry of Health at Uganda. Mr. Morris, principally, he's a pharmacist with a background of public health specialist and health economics. Mr. Morris is holding a Master's of Pharmacy from the Pentecost Institute of Pharmacy. He also has a Master of Public Health specializing in health economics from the University of Cape Town. Mr. Seru Morris has an experience of 30 years working as has been involved in the development, management, and implementing medicine management programs. He has coordinated also the review of medicine policy guideline, like the Uganda Clinical Guidelines and Essential Medicine and the Health Supplies List of Uganda. Mr. Seru Morris has been a member of the National Drug Authority, where he has chaired the Committee on National Formulary, but also a member of Committee of Essential Medicine. Mr. Seru Morris, he is also the National Pharmaceutical Expert for the MedSafe project on combating substandard and falsified medicine and health products in the Eastern and Central Africa. So, Mr. Morris, you are being given 10 minutes to present the supply chain and the logistic management in healthcare perspective in Uganda. We would also listen the best experience and lessons and strategies going forward in regard to a supply chain and the logistic management in primary healthcare in Uganda. So you're warmly welcome and proceed for the presentation. Welcome. Over to you, Mr. Morris.
Thank you so much. I'm trying to share the presentation. Is my presentation shared? Can you see the presentation?
Yes, we can see it. Yes, please proceed.
Okay, thank you so much for that elaborate introduction. And I would want to thank the organizer. I'm trying to make the screen bigger. Just a minute. Okay. Yes, for that introduction. And I want to take this opportunity to thank the organizers for inviting me to this very important session where I'm required to give insights of supply management and logistics management in primary health care in Uganda. And that's the outline of my presentation. I'll give you a quick overview of the healthcare system in Uganda. Then I will go through how we select our commodities, how we finance them, how we procure them, how we distribute them, and at the end, I'll give you the lesson learned and strategies going forward. As given the time given, this presentation will exclude the management of commodities like ARVs, TB, and family planning, because these are centrally planned, and if I dwell into them, 10 minutes won't be enough. It will also exclude medicine management of commodities in private, for profit, and private, not for profit. If time allows, I will speak to that like a little. So it's important for me to give you an overview, because for you to appreciate the subsequent slides, it's important for you to understand this one. In Uganda, our national healthcare system has the national referral hospitals. Those are two. One is general, another one is for mental health. We also have Center for Excellence, this Cancer Institute, Heart Institute, and Women and Neonatal Hospitals. But also we have 17 regional referral hospitals in the country, with each of them with a catchment population of around 2 million. Then we have 62 general hospitals. These are public, with a catchment population of 5 million. We have health center of 500,000, I think. We have health center 4 with a catchment population of 100,000, and health center 3 with a catchment population of 20,000. But also health center 2 with a catchment population of 5,000. We also have VHT, which is normally community, which is normally known as, these are village health teams, which are normally known as health center 1, with population of 100, with a catchment population of 100 and below. Now, how do we select our commodities? I will dwell, when we talk of primary health care, I'm going to speak to mostly health center 3s and health center 2s and health center 1. What we do, the range of commodities the facility gets depend on the level of care. For instance, if you're at a level health center 3, all the facilities at a level health center 3 in the country receive commodity, they get the same range of commodities. And this is well defined in our essential medicine and health supply list. When we develop a health supply list, we also put in common where that commodity is supposed to be found. That means, for instance, if a commodity is at health center 2, say we'll put there health center 2. That means can be right from health center 2 and above. If we say health center 3, it means it starts from health center 3 and above, excluding health center 2. If it's at a hospital level, it means from hospital level, referral hospital, and national hospital, excluding the lower level facilities. And how do we define this? The range is determined by the capacity of the facility in terms of infrastructure and human resource and budget. Because when we're developing our essential medicine list, we know the capacity at all these facilities, and depending on that, we define what they should have. And of course, the budget constraints. Let me now speak to financing. Now, for instance, all health center, for instance, all facilities at the same level of care get the same budget irrespective of the workload. That means in the country, for instance, if you're at the level of health center 3, irrespective of where you are, your budget is the same. This has its own challenges, which I will explain later. But over time, we have realized this is not good. What we do usually now, if finance gives us more money, now we don't distribute that money accordingly, equally. Now we factor in variables like workload and other variables like the human capacity available at those facilities. Then when we go to procurement, for us, we have a centralized procurement system. We have our national medical stores, which procures for all facilities, right from national to the lowest facility. But however, the procurement plans are done locally. For instance, each hospital makes its own procurement, but for instance, based on the range of products supposed to get. For instance, the health center 4 will say, your range of products are this. The money we're giving you is this. Can you make your procurement plan? That means from health center 4 and above, they do that. But for the lower levels, we agree in a district, for instance. We say, this district, this is the budget you have. This is the range of commodities you are supposed to what? To budget for. So what it means, as I said earlier, all the facilities at the same level have the same range. However, the quantities may differ. Because a certain district may say, for us, we have malaria morbidity is high, therefore we're going to go for more ACTs. Another district may say, for us, our let's say pneumonia, the areas are high, so we're going for much more. So the districts have the flexibility to decide how much of what to buy, but not what to buy, because what to buy, the range is already what determined. That's what. However, the quantity of each product differ from this to district. Now, all this product, once this procurement come in, they are all aggregated at the national medical stores, where now an annual procurement plan for the country is made. Now, when we come to distribution, again, national medical store is mandated to distribute commodities up to the facility. But what they do, once they receive these work plans, procurement plan from facilities, they divide them into 6 equal parts. And therefore, every 2 months, they deliver to facilities. However, as I said, health center 4 and above, those make their bi-monthly orders. But health center 3 and 2, those which are the lower one, for them already, they've agreed, they have kits. We've agreed that every quarter, every 2 months, you're going to receive this kit of similar commodities, but different in terms of quantities as defined earlier by the district. So what happens, every two months, National Medical Stores delivers a kit to each facilities, depending on the level of care. And the good thing here is at health center, those health center 4 and above, they have some flexibility. For instance, if you put in your work plan that will be getting, let's say, 50 vials of ceftriaxone every 2 months, you have flexibility of 10% plus or minus. Depending on the consumption, you can say, this time you'll order for 40. This time you'll order for 60. But you can't go beyond that flexibility of 10, because once you go beyond that, you distort National Medical Stores planning cycle. And the beauty with this, it helps National Medical Stores to make framework contracts with suppliers, because they know the budget and they know what facilities want. But also it helps them to plan for call off on time, so that they can receive what we call, they can get product just in time instead of having to store them for long. And also and you see, most of our clients, patients who go to health center 2 and 3, this is the biggest, these are the majority of health centers. So because any National Medical Store knows their kits, because their kits are predetermined, so it prepares this kit early enough. It doesn't wait for orders. So this prepares them early enough so that it's very easy to distribute. They pre-pack them.
So Mr. Seru, you are remained with almost 2 to 3 minutes. So
okay,
yes.
It's okay. So now again, so what I'm saying, this also saves health center 2 and 3 from making frequent orders given their limited human resource. Now quickly let me go to the lessons learned. Facilities have different demand, even if they are at the same level and in the same district. I think that's clear, don't need to explain much. You'll find similar facilities, but the workload of the facilities is different, and yet they're getting the same amount. Many districts, for one reason or another, lack the capacity to make good annual procurement plan. Despite all this, when you get procurement plan, they have a lot of errors. Lack of accurate, reliable data makes the exercise of making annual procurement plan tedious and time-consuming. It takes a lot of time to make this procurement plan. Some lower-level facilities, especially in urban areas, have more resources than what's expected of their level of care. You'll find a facility which is supposed to have a clinical officer, but has a doctor, and yet it's on low-level care. It's at low level of care, so that doctor is not fully utilized. So what are the strategies going forward? What we're doing currently, we are piloting facility kit as opposed to district kit in some districts to address issues of workload and facilities capacity beyond their level of care. What we're doing now, what we've been having, as I mentioned earlier, all facilities, for instance, at level 3 in the same district get the same quantity of commodities. But now we're piloting, whereby now we're putting a facility kit depending on their level of care. So you'll find now a facility which has more workload, their kit is has more commodities than the facility which has few.
Thank you very much, Mr. Seru.
Then lastly, we have employed regional logistics officers to regularly mentor district facility or inventory management and procurement planning. Yeah, I think the last one, we are in the process of digitalizing supply chain. We want to digitalize our supply chain at all levels of care so that we can get real-time data for our planning. Thank you so much.
Thank you very much, Mr. Seru, for a very nice presentation. So quickly, the audience will have noticed the following. Mr. Seru has explained a lot on most of the vertical programs commodities. And we haven't much listened on the essential commodities, how the facilities get the essential commodities. But there are a number of health facilities with the level he has explained. We have also seen how the commodities are being selected from the national listing. The level of the facilities receive the same medicine, but come up from the essential listing. The financing, the procurement procedures, we have noticed the presence of the National Medical Store Department, which actually deliver the commodities to the facility level in every 2 months. But he has also said in the lesson learned, there is a compromised data accuracy that is coming directly from our facilities. You will have more time to ask the questions, but you can go through the chat box and start asking the questions. Meanwhile, I'm introducing another speaker who is here to present as our second speaker. Our second speaker is Madam Fozia. Madam Fozia Mohammed is a guru with a great experience in supply chain management and pharmaceuticals. Currently, Madam Fozia serves as a special supply chain advisor for HIV, TB, and malaria. He has a role of a valuable advisory role and contribute the supply chain management at the chief of staff at the Ethiopian Pharmaceutical Supply Chain Agency. Prior to this post she is holding, she has been serving as a chief of staff at the EPSA at the Director General Office. She played a pivotal role in supporting the Director General Office, utilizing her exceptional organizational skills and leadership abilities to ensure smooth operation and effective decision making. She has, through her career, Fozia held various positions, including warehouse management, inventory management officer, transit officer, procurement officer, medical equipment surveillance officer. These roles have provided her with comprehensive knowledge and hands-on experience in supply chain management and pharmaceutical operations. Before joining Ethiopian Pharmaceutical Supplies Agency, Fozia worked as a druggist and later as a pharmacist at Aberus Pharmacy. Fozia holds the following background education. First, she has a Master's of Arts, a degree in Logistics and Supply Chain Management from the Addis Ababa University School of Commerce. She also has a Bachelor of Pharmacy degree in Pharmacy and diploma. With her extensive experience, expertise in supply chain management and dedication to improving our healthcare delivery. Now, may I welcome Fozia. You are being given 10 minutes to present an experience from Ethiopia. You're welcome.
Thanks, Mr. Sheo. Will you hear me?
Yes, we are listening. Can you proceed?
Okay, thank you. Yeah, okay, thank you very much, Joel. Thank you for the participants who are joining on this team. So I would like to rush because I have 10 minutes for this presentation. And the supply chain has a vast feature to be presented here, but for the sake of time, I would like to rush. Here is my outline for the presentation. And if you'd like, there are some foreigners here in case if you need to know Ethiopia, this is a Horn of Africa and having a great, rich geographical diversity. If you can tour and visit here, okay. So before starting to the primary health facility, I would like to give you some overview that we have been a 75 years experience of within this supply chain management. We PSCs, Ethiopian Pharmaceutical Supply Service, have a 17 years experience that starting from 1947, having a main pharmacy, retail pharmacy. Now it has reached to the $1 billion transaction agency that procure and having a vision in 2030 have a big pharmaceutical supply chain organization in Africa. So then after I giving overview about the APSCs, I would like to go to the introduction firstly. Here in Ethiopia, there are greater than 17,000 primary health care. That means 17,000 health posts and 3,700 health center. And there is also 353 hospitals, and also there are 47 hospitals under construction, which will be functional nearly, categorized into 3 groups: primary, general, specialized, including the teaching hospitals. When you see the serving population, as you see in this figure, the health center and health posts, when you compare to rural and urban area, even in the health center, 40,000 people are served under the health center, and in the health post, the maximum of 5,000 people are served. So then in this health supply chain system, we have been focusing that on primary health care delivery system, which how commodities can be delivered to this primary health care unit. When you see our strategic plan, we have been addressed that starting from 2015 up to 20, we have a strategic plan nationally that it was, when you evaluate the strategic plan, it was marked that it is increased the life expectancy at birth. And also now we have transformed to the next health strategic plan, and we have been at the point of mid of the year that having 14 strategic direction, including Warada transformation. Our strategic plan have been focused on this primary health care. Exploring from this strategic plan, we have PSTP2, that means pharmaceutical strategic plan, which will be drawn from this HSTP plan, which will be mainly focused on the pharmaceutical supply chain system. So when you see this delivery system, we have been 19 outlets to be reached to these all facilities, categorized by six clusters. This categorization is not region-wide. We can serve across the region and inside the region and intra-region. So these all 19 hubs of the APSCs, including the head office, we have 20 outlets. So we have reached by these outlets. When you see the access of essential medicine, our priority is that we are planning to satisfy priority healthcare need of the population by adoption of the essential medicine list and pharmaceutical procurement list. We have a monitoring system that all tracer drugs have been available in the primary healthcare, and also we have focusing on the affordable price, that there is bulk procurement centrally, and there is a CPHI, that means the insurance policy, tax exemption, and also so as to make the price easy for the health facility. The health systemic finance system that we following is this, there is a CPHI system, as I mentioned before, and also there is free exemption service. When you see the overall system of reliability, we have been procuring using different modalities like frameworks, committed demand, and integrating with traditional medicine. I will come up on the procurement system, so I will rush on this PowerPoint. So there is also a developing system to monitor. There is KPIs, which are monitoring tracer drugs, which drugs are available in that national level and also at health facility level. And we are transforming our rationing and quota base starting from 2007 into the IPLS system, so as to make sure that the product supply sustainability and also monitoring and reporting system of the health facility. So when you see the IPLS, that means the Integrated Pharmaceutical Logistics Supply System. It is a single pharmaceutical reporting system, which includes this logistic management information, mainly inventory control system, storage management, and related warehousing. These all practices are involved in this IPLS system. When you overview this figure, there is international and local sources. We have been procuring both from local and international sources. Here is Ministry of Health and Regional Health Bureau. There is bilateral communication both by information and product flow. So this central EPSCS sent to the products to 19 EPSCS hubs. Then the EPSCS hubs directly deliver to hospitals where health facility and health posts, and also there is indirect delivery by Wereda Pass-through, which has an infrastructure difficulty for high trucks. Wereda will deliver the products. Now we are working for increasing the last mile delivery to reach out lastly to the health posts. Then when you see the reporting period, there is RRF, the format health facilities are using to forward their reports and consumption and requisition, and it will be managed by every 2 months. And also, but for vaccine, it is every month. But for some regions, we are been piloting that the western part of Ethiopia and our some zones are incorporated in the pilot to be delivered products every month. When you see the overview of the supply chain process, there is selection will be nationally held that we have been using the essential medical lists and medicine lists, and also there is this pattern criteria, and also there are many criteria. Healthcare service level also considered in the selection, so the health facility select their products according to their disease pattern area, and also based on the treatment guideline, including the essential medicine list. Now, when it comes to the quantification will be aggregated nationally at EPSCS and MOH, but when the data comes from the health facility that our 19 hubs are supporting the health facility how to quantify products according to their demand. And for in cases that has a service level, they are using a morbidity method. Mostly they are using consumption method. Sometimes they can use the mixer method of quantification, but all the quantification will be aggregated to our hub level, 19 hubs, and the 19 hubs will forward to the central level, and the central EPSCS will finalize the quantification and proceed to the procurement. But now we have been applying that there is committed demand system that health facilities should reserve their budgets due to the according to their committed quantity of the pharmaceuticals. When it comes to the procurement, all the procurement system, all products will be procured centrally at EPSCS that we have been using a long-term agreement so as to protect products.
2 to 3 minutes, so keep summarizing. 3 minutes.
Okay, and we are using the electronic method HGP. So the storage is centrally managed. All products will be stored regardless of the procurement agent. All products will be stored as central EPSCS, and the distribution in and reporting mechanism is by every 2 months, and there is a monthly basis for vaccine and some zonal areas. So when you see the reporting system, there are reporting system, MOH facility to EPSCS, EPSCS hub to central EPSCS to MOH, and from health facility to EPSCS hub. There is a central reporting system that every distributed quantity of items will be forwarded to the parliamentary body government to be monitored, which item is delivered to the health facilities. So there are many technology we are using. For the sake of time, you can see here there are many technology we are using to assure the product sustainability and monitoring the stock status of the health facility. Then there are so many achievements. You see here we have placing a laboratory machine placement so as to increase the diagnosis of health facility, and also we have ISO certified warehouses. There are so many indicators here. So I can rush you where I saw certified warehouses also.
You're given 1 minute to end up.
1 minute only. Okay, we have so many challenges regarding on COVID-19. We have doing some intervention that reintegration of pharmaceutical refill with other products, establishing emergency task force, and that there is essential supply chain emergency capacity building with conjugating with donors also. There is joint supportive supervision yearly based so as to monitor the primary health facility care, their products, their system in the operation also. There is a conflict challenge here nationally. It affects the distribution channel, but we have been using airlines and also other distribution modalities. This is all about my presenting. I would like, I am very rushing to finalize my presentation. Thank you very much for hearing. So over to you.
Thank you very much, our second speaker, Madam Fozia, for a very nice presentation and experience from Ethiopia. We have listened you just to go in summarizing what you have said. You have a number of health facilities, starting from the health posts to health centers and health and hospitals. The delivery system has around 19 hubs with 6 clusters. There is an access, affordable and sustainable financing for the health commodities. You are currently practicing the kit code system, but you are in development of the pool system for the facilities to access the commodities. You have also IPLS system, your distribution pattern for the commodities to the facilities by monthly with an exceptional for the vaccine, which is in every month distribution. You have said the quantification of the commodities is done at the national level with an assistant of data coming up from the 19 hubs. By using the mobility and the consumption method is used for the quantification. There is a problem, as I have listened clearly, problem with data quality and some sort of confliction in an area of distribution. So we are thanking both the speakers for a very nice presentation and experience and the best practice to the audience. We are now coming to the question and answer section. Earlier I said you could make questions to the chat box. So with the questions that have been asked earlier, may I welcome our first speaker to respond to the questions that have been asked at the box chat. And then we'll go to the second speaker, and then we'll give time the audience to say if the time is in our side. So Mr. Sero, please, can you go through responding the questions which have been started asking at the chat box?
Okay, thank you. There is what impact of the push system telecenter 2 and 3. Before we started the push system, all these telecenters used to make orders. But what would see, they would have delayed, they'd take time to order. And the delayed ordering would lead to delayed distribution and rampant stockouts. But with the push system, NMS is able to give in-time delivery to facility because they plan ahead. They keep these things already pre-packed. At the end of every 2 months, commodities are delivered immediately. So it's solved that problem of late delivery. Then what factors contribute to commodity expiry? Why do experience non-compliance to rules regulation? Now, I think the factors that contribute to expiry, one, when it goes some of the change of policy and treatment. At times, especially for HIV/AIDS, the policy change and then we change regimens, and those commodities we already procured earlier do expire. But what we do nowadays, we make sure if we're going to change policy and treatment, we make sure we do seamlessly transition. We make sure that the old legacy commodity is utilized, and then so that we introduce the new one in phased manner. Then, of course, with this push system, at times when they've done poor procurement planning, they end up putting things. You give them more than what they require. But again, the way we mitigate that one, we have what we call redistribution. the district is able to redistribute commodities from facilities which have more to facilities which have less to reduce to that expiry due to what? To oversupply. Then what else? What factors that I mentioned? Since procurement and distribution that I don't understand, what is it? Let me see. Since procurement and distribution of commodities are central, how could health center 2 serve it directed delivery or the no. What I said, National Medical Center is responsible for delivery right from the health from their stores up to the facility. What they do when the big truck delivers, they have a sub store at the districts where they attempt to subcontract other entities to do now the what? The last mile deliveries to what? To facilities. What else? I think. Then the others I answered in the Q and A chat, I think. Yeah. I submit, Chair. Chair, over to you.
Yes, thank you for the response, Mr. Morris. Now, can we turn to Madam Fozia while the audience is still asking the questions in our chat box? Please, Madam Fozia, can you respond to the asked questions?
Okay, thank you. I'm actually typing for question number 2, but to give you some reply on question number 1, there is a question that how you are monitoring the IPLS at health facility. I think this was the question that in last mile delivery, we are applying this IPLS system that the report will be always forwarded to us every 2 months. That in that section there is health facility stock levels, and also health posts are considered as a dispensary unit for health facility. So then all the transaction of health posts will be recorded in the due section of the RRF, so we can monitor that one. When I come to this, the next question, there is a question that what is the system in place that to ensure product availability and wastage rate for health commodities? It says that it depends on the scenario of the healthcare level, that when you come to the central level and branch, there is HSMI system, and also there is a dashboard system, which every external body can see that dashboard system regarding on availability, but there is internal dashboard also. There is also a national dashboard system, which will be visible for all our higher officials, including Ministry of Health, so that we can see that the amount of the availability of the product and the rate of wastage of the health commodity. This is the scenario that we are applying for central and branch level. But when you come to the health centers, primary health care, there is a system, the so-called DAGU system, electronically set on the health facility. Every transaction is recorded and synced to our dashboard system, so we can see the reports every 2 months. But for health facility, we are not using this DAGU system because of the infrastructure problem. There is a RRF reporting system, and we can calculate from that there is consumption on and request there. So there is a reporting column there so as to monitor product availability in that healthcare level system. Thank you. So over to you, Mr. Chair.
Thank you, Madam Fodia. So to Mr. Sir, there is an, I don't think if you responded the question on emerging supply chain in reaching the desired level. Yes, could you please respond for the emerging supply chain? Together with the changes, what are the major challenges in mixing the supply chain for the pharmaceuticals and the vaccines?
Now, for emergency, for us, when it comes to emergency, we hand it centrally. Especially for epidemics, we manage it centrally. So what we are trying to do currently, especially after that COVID and Ebola we had in December, we are trying to make regional hubs. Like I mentioned of regional referral hospital, we're trying to make sure at every regional hospital have a stockpile of some of these non-emergency medicine and emergency PEPs, so that if there is any outbreak, instead of waiting for Kampala and what, the regional referral start working with the stockpile they have at the regional level, as we mobilize more from what? From the central level and the abroad. Now, for the vaccine, I think it's a challenge to us, because like I said, personally, I'm responsible for health supply chain and all pharmaceutical related issues, but it seems the vaccine is running slightly parallel with their own logistician and what. However, for us, when we go to supervise and mentor, we don't look at vaccine as a separate commodity. We look at it as as also a commodity. But there's a challenge. They're still in that mode of parallel, which we are still trying to address. It's slightly a challenge there. We still have a challenge there. Unlike other programs like HIV, AIDS, TB, reproductive health, those are purely integrated in the main supply chain, but vaccine will still have a challenge. I don't know whether I've answered it.
Okay, they're also asking about in Uganda, is there a dedicated structure to facilitate the supply chain and other commodities from the district level to the national level? Is there an existence of such a structure before?
Yes,
and how is it working?
I think the structure is working. If you followed my presentation properly, I showed you how we do the selection. I showed you how we do the procurement. I showed you how we do the distribution. That's for the public sector. But at the same time, there's another similar structure, especially for the private not-for-profit. Of course, when it comes to selection, they use the same criteria. Now their distribution system their financing system is slightly different, because now PNFP also, apart from getting government subsidies where they get medicine from GMs for free, they also have a line where they procure. They use their own money, the money they generate from their income to procure from what? From joint medical store, but also from the private sector. So the structure is aligned to those different components of the supply chain cycle. And if at time, I wish I'd known, I would have given a diagram, a diagram showing how those things move. But it's there.
Okay, thank you for the very nice response. Madam Forgia, there is a question here. They're asking about the forecasting. Are there problems with regarding to forecasting? Can the problem be solved by aggregation from the zonal regional level? It is as if they haven't understood the quantification process, where actually forecasting is part of the quantification. So they're asking whether the problem can be solved by using the zonal or regional to resolve the challenges with regard to forecasting exercise. Can you go through, please, Madam Fozia?
Okay, thanks. I'm looking another question also in the chat box, that how CBHI is working at health facility. It's been working that customers will reserve a prepayment every year, and they will get a service with free of charges. Then maybe many people reserve that payment, but they are not using the service, so that will reimburse the other costs. So then after every schedule, the CPHI team will reimburse the health facility service for the patients. When I come to the second question, I saw that there is a campaign of shortage of supplies and drugs at health facility, and what will be the reason behind that. Say supply chain is a very complex that we can manage customer complaint. The answer will be contextually will be answered, because shortage will be arise for different pharmaceutical. There may be some different reason, but so as to alleviate this kind of problem, we're reaching health facilities by joint supportive supervision, how they can forward their report quality, data quality reporting for central and branch PSCs, and how they can monitor their stock management and how they are using their schedule appropriately, and how they can send their reports timely so as to get the products at timely basis. So this national supply chain system can be addressed, the shortage and the availability in the other wastage rate also addressed by such kind of this approach. When I come to the forecasting problem, actually forecasting has been done at facility, not at region and zonal level. We by ourselves, and the Ministry of Health has given training how to quantify products yearly basis and how to reconcile their budget toward the forecasted quantity of the commodities. So all the forecasting and quantification process will be finalized at the health facility level and will be forwarded to central, and the central team will validate their budget allocation and also their quantity. After reconciliation have been done, there will be an aggregate forecasting or quantification total quantity at national level. I think I'm addressed all the questions. Thank you.
Oh, thank you very much for a very nice response. Can you go through on the question which is asking, is it a good practice to reduce waste rate by 0.7% at EPS center? Would you share the experience on how to reduce the wastage rate at facility level?
Yeah, this figure has represented all the national EPSCS data that has been aggregated from all central level. The WHO reference target for wastage rate is 2%, but we put the baseline to make our wastage rate less than 1%. So we have been doing that. There is a quick initiative, and also we are reaching for some facilities every month, and some other are every 2 months, but so as to approach the communication, we are using the refill schedule by every month. And also there is a quick initiative, and also there are some platforms aligned with zonal logistic officer. The zonal logistic officer is working on products that if there is any product which is a potential to expiry, they will inform our outlet hubs so as to make some redistribution plan. So by this approach, actually we have many approach we are using, because we are working for so many years to get this figure, to reduce this wastage rate. So then by this approach, we are lucky to have this kind of figure of wastage rate. Thanks.
And the last question for you, Madam, they're asking, what is the major challenge for the integration of vaccine and other pharmaceuticals in the supply chain system? The question that was responded by Mr. Seru. Can you also respond?
Yeah, good.
Yes.
When you see the nature of the vaccine, it needs some cold chain transportation. So you only can manage that with cold chain commodities, but it's not recommended to these antigens to be integrated with other medicines. So we're using cold box and cold vans to distribute this vaccine. So the nature of this vaccine can hinder us not to integrate with other products, but we can integrate with the schedule with every month, but we couldn't integrate with the same vehicle because of the nature of the products. Thanks.
Oh, yes.
Yes, Mr. Seru, do you have anything to add?
No, could be what I missed to say in the presentation, which I put there. You know, I mentioned about village health teams, the health center one. For those ones, we don't plan for them separately. They are planned by the facility nearby to the village, and their delivery and reporting are included in the facilities reporting and deliveries. That's what was the last that was my last slide, which
Yes.
I didn't.
And Madam Fozia, for 1 minute before I give you an experience of Tanzania, just 1 minute for 1 minute. Yes, Madam Fozia. Probably you have something you have forgotten to clarify to the audience.
Yeah, actually, Actually, I have included in my presentation. I would like to say many things to share my experience over all the supply chain management, but due to time restriction, I couldn't add anything because I have so many things to add. So thank you very much for attending and for joining us this presentation. This is the objective of this presentation has to share experiences between countries in countries and intra countries. So we African are the same, so we can share our experiences by any time. So I saw that many chatters here from my country also, they're appreciating us and also giving some additional information about the supply chain. Thank you all for adding your inputs here. And next time we will have summarized and short and another exposure in this supply chain system. I'm just grateful to have this floor to share my experience and my company's experience and my country's experience. Thank you.
Oh, thank you very much. Maybe I give you for a 1 minute an experience from Tanzania. In the primary healthcare setup, we have around 6,000 plus health facilities divided in dispensary level health centers and hospitals. And we have an experience of more than 10 years using the electronic logistic management information system, where every facility is having its own account, where it has to report what it received from the medical store department and what it utilized. So we are reporting on every month, and we are requesting in every 2 months. So the MSD, our medical store department, is doing direct delivery of the commodities to the primary facilities. And actually, we have what we call the pull system in comparison to push system. So the facilities are requesting based on what they need, not based on the standard list which is coming up at the Ministry of Health. But also we have what we call a bottom-up quantification, where the facilities plan themselves and state what do they need for the coming financial year, the commodities. So they say themselves, because under quantification, we have forecast, we have funds commitment, and we have the supply plan. So the facilities, they do themselves. Nobody determined for them. Previously, at the national level, they were doing, specifically for the vertical program commodities. But currently, for the essential commodities and the vertical commodities, the facilities do themselves, quantify themselves. So whatever comes, the expiries, the shortage, the facilities will be responsible for themselves to say. Now, coming up to the winding of our program, because we have 1 minute to go. May I thank very much the director of program for the International Institute of Primary Healthcare coming up from the Ethiopia for organizing such a very nice meeting for us to get the experience and the back and best practice for the supply chain. My request is, can we have more forums, because we have a very limited time for such today's meeting. So let us request our director of programs to arrange more meetings so that we can get a more experience which can reshape the supply chain of our countries. With those few words, may I welcome our director to close up our meeting. Please, Director, Dr. Anten.
Okay, thank you so much, Mr. Matthew, for excellent moderation and leading the session. Dr. Antenna is not available for now, I'll be sharing a little bit about the session. So thank you again for the moderator and for the nice speakers for the ideas and experiences shared from Uganda and Ethiopia. It was an excellent session. So I would also like to thank our audiences for an active engagement and sharing the experiences and the questions forwarded was very interesting. So I thank you for the speakers. They tried to respond most of the questions on the Q&A sections and also on the live. But for those not addressed questions, we came organized and sent to the speakers so that they could give the responses and return back to the audiences the responses. So probably we have a committee of practice. You could get it on the on our website. So we may also have could use that opportunity to share, to have a follow-up discussions and sharing experiences in the community practice of the primary health care. So please use that platform as well so that we could share the experiences. So the link is on the chat box, so you could use and join the committee of practice. So this is what I would like to say. And also the webinar sessions will be followed up with different topics. So if the interest comes again, we may also have arranged another session after some time in the supply chain as well to have more discussion and hear from other countries as well. So please follow us on our websites, and our monthly webinars will be followed up. We have also different courses on our sites, so please check on that, and you could use those opportunities as well. So thank you again for the panelists and as well for the audiences for being with us, and stay tuned. We'll have opportunities coming up. So thank you. Have a good day. Have a good evening for everyone.
Good evening.
Thank you very much.
Thank you.
Thank you, everyone. Bye-bye.